So let's get right into the program, and it's my pleasure to introduce our first speaker, Dr. Daniel Sewell. He's a clinical professor of psychiatry at UC San Diego and the medical director of the Senior Behavioral Health Program and the director of the Geriatric Psychiatry Clinical Fellowship Program. He also serves as the Associate Director of the Hartford Center of Excellence in Geriatric Psychiatry and oversees the Physician Educator track for the Geropsychiatry Clerkship at UC San Diego. He's a Distinguished Fellow of the American Psychiatric Association and is board certified in psychiatry with added qualifications in geriatric psychiatry. He has served as a member and chair of the board of directors of the American Association for Geriatric Psychiatry and their education committee. And in 2005, he was the recipient of the Leonard Toe Humanism in Medicine Award from the Arnold P. Gold Foundation. And his research career and scientific publications have focused on behavioral abnormalities and make him a leading expert in in his area in the contribution for dementia. So thank you very much, and welcome aboard.
Good morning. I'd like to start just with a thank you to Dr. LaFurla and the UCI Alzheimer's Disease Research Center and the other co-sponsors of today's conference for inviting me to be with you this morning and to be a part of such a distinguished group of faculty. I also want to begin by letting you all know that during my talk I have included a few cartoons. And I want to be clear that this is a very serious topic that we're addressing today. And I want to be clear that I don't mean to in any way give any other message, but that this is something very serious and it impacts people's lives in very devastating ways. That having been said, I believe, both as a person and as a professional in the field of psychiatry, that we should laugh more. And even in dark moments, I think there's a place for laughter. So I do hope that the few cartoons I have included this morning do not insult anyone, but also I hope that they give you a chuckle, because I think laughter is good for us in many ways. These are my disclosures, and I'm not going to pause too long on them. I do not believe that any of my disclosures have any bearing on the content of my talk this morning. This is an outline of what I'm going to cover in the next 25 minutes, and I'm going to do my best to reserve about 5 minutes for questions. I'm going to start with a review of my key points, so for those of you who are still waking up, just hang in there for a few more minutes, get my key points, and then you can relax and maybe catch a little more sleep. I'm going to give you a brief overview of the common problem behaviors that occur in patients that are living with dementia. We'll talk about the differential diagnosis of behavioral symptoms in patients living with dementia. Differential diagnosis is the term we use to describe a list of possible explanations that might be underlying the behavioral problems. We're going to talk especially about the role that medications play when we work with individuals who are living with dementia. You know, medicines are a mixed bag. They can be very helpful, but they also can be very problematic. And in the unit where I work in San Diego, we unfortunately see a lot of avoidable problems related to really imprecise, suboptimal use of medications. We also will talk about what is the appropriate way to evaluate a person who is presenting with behavioral symptoms in the context of a dementia illness. I hope to have time for a couple of illustrative cases, and I may actually skip some stuff to get to those cases because I think they really spotlight some of my key points, and then lastly, I'll be summing up my key points. Well, key point number one, new behavioral problems or rapidly worsening pre-existing behavioral problems indicate, in my opinion, the presence of an underlying medical illness until proven otherwise. And my bias is that this is one area in our healthcare delivery system that we currently fall down on. And we are not doing a good job of this. And when we don't do a good job, everyone loses. The patients with dementia suffer, their caregivers suffer, and we all suffer in that we are spending money that gets us nowhere and it's wasteful. And we have lots of other needs in our society as well, so it would be smart for all of us to do this better than we currently are. The first step in the evaluation is to assess, is there an underlying medical issue that could be triggering these behaviors or at least contributing to the behaviors. Again, I want to emphasize that a big issue that triggers problem behaviors in patients living with dementia are medications. So we're going to spend some time talking about various categories of medications, especially medicines that have what we call an intrinsic anticholinergic effect. I'm sure most of you, if not all of you in this room, understand that one of the key biochemical problems in the brains of individuals living with Alzheimer's disease is a lack of the chemical messenger acetylcholine. And there are medicines, unfortunately, that have a side effect that contributes to that deficiency in acetylcholine. So the last thing that we want to do to someone living with Alzheimer's dementia is to give them medicines that worsen one of the primary biochemical deficits that they're living with and is responsible for their difficulty with memory. Unfortunately, some of these medicines that are anticholinergic are not widely understood to be anticholinergic. And so there are a lot of physicians and other clinicians who prescribe these medicines without recognizing that they are anticholinergic, and they probably shouldn't be prescribed to a patient with Alzheimer's disease. The fourth key point I want to make is that when we assess people who have behavioral symptoms in the context of a dementia illness, we have to obtain a very careful history. And sometimes that history alone is all that's necessary to illuminate what the problem might be. And what we especially tune into are temporal associations between the appearance of a new medical problem or the introduction of a new medication and then what happened subsequently. And often what we find is that there is a time connection, that within a short period of time of a new medicine being introduced, behavioral problems emerge. And then that helps us quickly figure out how to fix the problem, get rid of that medication. We also know that there are other things that can give us a clue to what might be going on in terms of the behavioral symptoms. And one of the points I hope to make this morning is, how do you distinguish between psychosis in Alzheimer's versus psychosis that can occur in other conditions? Psychosis is the term we use to describe a person who has developed problems with visual or auditory or some other form of hallucination and or delusions, which are fixed false beliefs that do not respond to an argument, a rational argument to the contrary. So those are my 4 key points. You can take a breath and relax. Here's my first cartoon. I think this cartoonist who creates the Pickles cartoon strip has done a marvelous job over the past few years spotlighting issues pertinent to those of us who are growing older or who already are older. So here you see the couple that's depicted in the cartoon strip having a conversation, and the wife says, "Listen to this quote by George Orwell. Every generation imagines itself to be more intelligent than the one that went before it, and wiser than the one that comes after it." And the husband says, "Isn't that the truth?" And the wife says, "Amen." And then their grandson appears on the scene and says, "I fixed your computer, Grandma. You didn't have it plugged in." Kind of humbling. Well, this graph depicts some research that was done at the University of St. Louis under the direction of George Grossberg and his colleagues. And what they did is they studied 100 individuals with autopsy-proven Alzheimer's disease. And one of the goals of the study was to make clarify for us the relationship between course of illness and which behavioral symptoms might be most likely to be present at that stage of illness. And so I share this with you because it can help us begin to understand what's happening. Because if we have someone who is very early in their Alzheimer's disease illness, who's having hallucinations or aggression, that's not what we expect. And that could be a big red flag that the symptoms are not directly a part of the Alzheimer's disease, but might be related to a new problem or different problem, like an underlying unrecognized medical condition. So what you see here on the x-axis, the lower axis, is time. And what they did is they actually interviewed caregivers at the time that the patient with dementia was being brought for evaluation. So the moment of evaluation is on the x-axis and listed as time 0. I don't know if I can, right here. So then they asked the caregivers, well, when did you first notice problems with social withdrawal? And when did you first notice symptoms of depression? And ultimately, they were able to translate their data into frequency information. And what you see here then is that the most common time that social withdrawal was reported by people who were caregiving for people with Alzheimer's was about 40 months prior to when they were brought in for initial assessment and diagnosis. So social withdrawal is one of the earliest behavioral changes that we expect to see in someone living with Alzheimer's disease. Also, early phenomenon can include problems with depression and even some paranoia, especially related to the inability to remember things and then coming up with accusations about what happened to those missing items, for instance. Around the time that people are brought in for diagnosis, the issues tend to be agitation, wandering, and socially unacceptable behaviors. And I think that makes sense. I think most families and caregiving systems do an amazing job of dealing with some of the earlier symptoms that we can see in someone living with dementia. But when problems with agitation or wandering or other socially unacceptable behaviors appear, that's when they call for help, and that's when they bring the loved one to a medical professional. As I mentioned a moment ago, problems with hallucinations and aggression are really late occurring symptoms for most Alzheimer's patients. So if you have hallucinations in someone who was just diagnosed, that's worrisome, and that might be indicative of a second problem called delirium. This is a list of some of the more common behavioral problems that we see. I understand this morning I'm kind of preaching to the choir, as they say, because I know that this group is very seasoned, and you've seen all of these problems perhaps, and some even not included. But there's a very wide spectrum of behavioral symptoms that we can see in individuals living with dementia, including food refusal, wandering, sleep problems, which we'll be hearing about shortly, problems with depression, psychosis, not cooperating with activities of daily living, and so on. Well, as you heard from Dr. LaFurla, these problems are very important for us to understand and be able to treat more effectively because they have very serious consequences. They are the leading reason for admission to nursing home facilities and other residential care facilities. The symptoms can interfere with activities of daily living. We know that there are associations between behavioral symptoms and falls, injury, and mortality. We know that these symptoms impact everybody. They impact the environment, they impact other patients in the environment, they impact the caregivers, and they increase the cost of care. This slide summarizes that differential diagnosis of behavioral symptoms in someone with dementia. And again, differential diagnosis is the term that we use to describe a list of possible causes. So at the top of the list, you see the term delirium, and we'll speak a little bit more about what that means. But other things need to be considered, like the exacerbation of a pre-existing medical condition. And there are many reasons why people living with dementia can have their pre-existing medical problems become problematic. For instance, the person who has the combination of dementia and diabetes, and then has food refusal, and has insulin in their system that drives their blood sugar down to a very low level that can be life-threatening, but also can trigger agitation, irritability, and worsened confusion. So you have to think, is this a medical problem that the person has been living with for some reason is not well managed at this moment? They could have a new medical problem because unfortunately being diagnosed with dementia does not protect you from the possibility that you could be diagnosed with another condition. And I think it's easy to forget that. It's easy to start blaming everything we see on the dementia. That's a big mistake. We also know, as you heard, that medicines can be a real problem for all of us, but particularly for people with brains that have been injured by a dementia illness. We'll speak a little bit about polypharmacy, which is the term we use to describe too many medicines being given, and we'll also speak briefly about another term called suboptimal prescribing, which is a term that includes too many medicines, but also includes other ideas, like the idea that maybe a person really does need a medicine for high blood pressure, but maybe they're not being given the most senior-friendly medicine to treat their high blood pressure. The concept suboptimal prescribing also includes the notion that there might be a medication that's missing from the medication regimen that could make a very big impact on the person's quality of life and behavior. And the biggest issue here, I think, is the absence of appropriate pain management. And we understand now how dementia can really interfere with our ability to accurately assess the presence of pain in a person who's living with dementia. And yet untreated pain can have huge ramifications. For instance, it can keep someone awake at night, and then the next day they're sleep deprived, and then it just snowballs because the sleep deprivation plays a role in irritability and problem behaviors. So suboptimal prescribing also includes then the idea that maybe a person should be on 2 regular Tylenol at bedtime so that the pain they have related to arthritis doesn't keep them up all night. We also have to consider possibilities like drug or alcohol intoxication. We've actually had family members think that alcohol might be a nice way to deal with agitation in their loved one. Not a good idea. And we also sometimes see unintentional problems with withdrawal, not because the family member or caregiver has been derelict in their duty, but because they just haven't been able to get that medicine into the loved one on a consistent basis. And so now their loved one is experiencing withdrawal symptoms from inadequate dosing of that medicine. We also know that people living with dementia can have a history of a prior psychiatric condition, and we're now beginning to understand that certain psychiatric conditions may actually increase the risk of dementia in later life, like recurrent mood disorders that have not been adequately treated. So we have to keep in mind that possibility as well. And lastly, we also know that people living with dementia can develop new psychiatric conditions because just like new medical conditions can pop up, so can new psychiatric conditions. We apply this list on every patient that we're asked to assess in our program. We systematically go down this list and ask, is it this, is it this, is it this? Delirium is defined as a mental disorder that is triggered by an alteration of normal brain physiology due to an acute medical problem. So this is one of the most common issues that we bump into in the work that we do on my inpatient unit. We see a lot of delirium, and we know that dementia lowers the threshold for delirium. And it is a signal that there is some significant medical problem that's impacting normal brain function, and that's then leading to the changes in behavior that are causing difficulty and that we're being asked to assess. Sometimes we've described delirium as an acute confusional state. In dementia, it would be often an acute confusional state superimposed on a pre-existing confusional state. We know that delirium is very serious and that if it's not recognized and treated, in some instances it can even be fatal, so it's not anything to take lightly. When I was in my training program many years ago, we tried to make the distinction between delirium and dementia pretty black and white. But over time, we realize now that that is not possible, and that although there are still some ways to distinguish between these two conditions, some of the things that we thought would help us make this distinction don't hold up as consistently as we thought. So for instance, it used to be that we thought that dementias had kind of a slow, insidious onset, whereas deliriums were abrupt in onset. But we now know that some deliriums actually do have kind of a smoldering, gradual beginning. We used to think that people with dementia would not fluctuate, but people with delirium through the course of a day could have wide swings in their alertness and ability to attend and have normal cognition. Well, now, thanks to our understanding of Lewy body dementia, we know that that doesn't always hold up either, because we know that one of the hallmarks of individuals living with Lewy body dementia is fluctuation. So we still try to make these distinctions, but it is a little more challenging nowadays than we used to think it might be. This slide summarizes some of the more common medical conditions that we can see in an individual living with dementia and that can then subsequently trigger problem behaviors. Here's a cartoon. It's a urology clinic, and the receptionist is saying to the caller, "Urology department, can you hold?" The cartoon is actually a cue to remind me to emphasize this relationship between medical illness and behavioral symptoms in someone with dementia, and specifically a reminder that we see, unfortunately, a lot of urinary retention in our patients with dementia. And trust me, those of you who've been in a situation where you're an hour behind schedule and getting to a toilet, you know how awful that is, right? Well, think about that feeling and also decreased problem-solving abilities related to your dementia. You're going to be very likely to get agitated, anxious, and upset. This is a slide that summarizes some work we did at UC San Diego, and I want to acknowledge a student of mine, Ben Wu, who's now on the faculty at UCLA. But Ben and I were interested in how many times patients referred to my unit actually were referred by clinicians who said, oh, they're medically fine. And then within a 24-hour period of their arrival on my unit, we uncovered, no, they're not medically fine. There's some medical illness here that nobody has taken the time to diagnose and treat. So we wondered, are we just kind of guilty of the ivory tower syndrome? Are we just being kind of snooty because we're UC San Diego? Or is this really an issue? So we thought, let's get the data. Let's not just go on anecdotal impression. And so we did. We spent 6 months looking at consecutively admitted patients, and every patient was seen by a geriatric internist within 24 hours of admission. And we asked, during that 24-hour window, how many were diagnosed with a medical problem, but nobody had told us about up front. Well, you can see here the percentage was 34%. That means 1 out of 3 people referred to my program is medically ill. And yet in the ED or in the doctor's office, it's all about, oh, it's just their dementia. Or maybe even worse, it's just that they're older. Older people are supposed to be like this. Not, okay? And the other thing that's really curious is the type of problems that we saw most often were not rare problems. They were not problems that were hard to diagnose, like severe constipation at the level of fecal impaction, or urinary infection, or hypothyroidism. And we saw 2 types of hypothyroidism. We saw some that was new onset, that had just appeared, and we saw some that actually had been around for a while and had been diagnosed, but nobody had taken the time to ask, is the patient taking their thyroid medicine as prescribed? And so the issue was non-adherence that led to reemergence of clinically significant hypothyroidism. Meds are a problem. This slide lists some of the common categories of medicines that can be bad actors in the lives of patients living with dementia. There's also that group of medicines that are anticholinergic that I mentioned in my introductory comments. I call them the stealth anticholinergic meds. And I've given this talk around the country and had primary care doctors question the validity of this data. They were just shocked to think that something like digoxin or furosemide or a form of prednisone could be anticholinergic. We believe that it is, and this is based on some research done by a colleague of mine at Emory University in Atlanta who developed an assay that allowed him to elucidate the anticholinergic load of medicines being commonly prescribed to older individuals, particularly those with dementia. Well, this is a cartoon that shows how medicines are tricky. A person's got restless leg syndrome, so his friend proposes that he put his feet in cement. Well, it fixed the restless legs, but now what? Okay? So we have to avoid medicines that are known to be more harmful than helpful in people with dementia. And I won't have time to go into this in depth at the podium, but beware of the Beers criteria. They've just been updated by the American Geriatric Society. The new set of criteria is marvelous, very helpful, and it's a list of medicines that should be avoided, if possible, in all older people, but particularly those with dementia. We've also studied the benefit of cleaning up these sloppy medicine regimens in people living with dementia, and what we found in a correlational study is improvement in function. This was not a study designed to have cause and effect outcomes, but at least it correlated. When we reduced the number of Beers list medicines in our patient population, at discharge, they functioned better. Okay, so this is a summary of the appropriate evaluation. I'm going to now skip ahead and talk about one case before I stop. This was probably one of the most tragic cases I've ever been a part of in my career. This was a woman who was 72 years old, and she was actually vigorous and robust and working in her 70s for the US Postal Service. But she had fairly rapid onset of cognitive loss and associated psychotic symptoms. Now, right away, rapid is a big red flag. Anything that happens rapidly, sounds very suspicious to be medical and not dementia related. Also, the nature of her psychotic symptoms did not fit the picture we would expect with someone who has Alzheimer's. Her delusions were very elaborate and systematized and included thoughts like Al-Qaeda terrorists were targeting her. She also felt that people were hiding under her car. She'd been seen repeatedly by her family doctor. She'd been seen by a neurologist. And then she had a fitness for duty evaluation by a postal physician. And none of them came to any conclusion other than she had dementia. So she was moved out of her home and she was placed in a dementia unit. Finally, a member of her family said, "This just doesn't make any sense. How could this be?" And they brought her to our unit. And thanks to the geriatric internist with whom I work, Dr. John Daly, he picked up on some mild calcium elevations. He then got the record from the family medicine doctor who had been caring for her. Guess what? There were a 2 or 3 year history of mild calcium elevations that the primary care doctor had not picked up on. He pursued it. To make a long story short, thanks to his diagnostic efforts, we discovered that this patient had a parathyroid adenoma, and because of her parathyroid adenoma, had developed dementia and psychosis. This is a story with mostly a happy ending, because we were able to treat her parathyroid adenoma, restore her parathyroid hormone and calcium levels to normal, and all of her symptoms cleared, every single one. The sad part is she never got her job back at the Postal Service, but the good news is at least she didn't have her home sold out from under her, and she was able to return to independent living in her home. But think about this. If this was someone that you loved, how would you feel about discovering that they had been sent to an Alzheimer's unit for the rest of their life unnecessarily? I have 2 minutes left. I'm going to squeeze in one last case. This is a case about Polypharmacy, or the Prescribing Cascade. This was a 92-year-old gentleman who was a retired engineer and had been living in his own home with caregiving support. But his caregiving needs increased, and a decision was made to place him in a residential facility. But for reasons we never understood, shortly before his placement, his primary care doctor stopped treating him with the antidepressant imipramine and prescribed him PRN risperidone, which is a new atypical antipsychotic, and it was prescribed on an as-needed basis. So he went to his boarding care, and the first night he had exaggerated confusion, did not sleep, and was given risperidone. How do you think he may have responded? I probably have set you up for the right answer. Not well. In fact, the next day he had decreased ability to walk, masked face, and drooling. So with those symptoms, what would you have done? Well, I can tell you what happened, which is the boarding care physician was consulted, and he was diagnosed with Parkinson's disease. And he was put on Sinemet. Do you think it helped? Well, after the addition of Sinemet, he became paranoid, aggressive, and stopped eating and drinking. So he was taken to a local emergency room and treated with IV fluids. He got better. He went back home, but the insomnia reemerged. And so a neurologist was consulted, and this neurologist recommended that the Sinemet be discontinued and prescribed olanzapine, another new atypical antipsychotic. How do you think he responded? Well, he became lethargic. He continued to be awake all night, and he went 7 days without a bowel movement, maybe because of inactivity, and maybe because of poor intake, and maybe because olanzapine is one of the most highly anticholinergic, atypical antipsychotics we know of. So he had a fleet enema. He was switched to a different atypical, quetiapine, but he still wasn't sleeping, and so they gave him Zolpidem, which is Ambien. How do you think he did? Well, he fell to the floor and started howling like a wolf. Poor guy, all at the hands of clinicians, I hope, who were trying to be helpful. So he also had agitation and visual hallucinations, and at this point he was referred to our program. This is what we discovered. He had low calcium, he had hypothyroidism, he had anemia, and he needed a lot of reworking of his diagnoses and treatments. But we did do that, and we actually ultimately helped him get back to a better place. In sum then, remember, new or rapidly worsening behavioral symptoms in someone with dementia is an indicator of a medical illness until proven otherwise. You have to think about underlying medical factors when assessing these patients. Remember that one medical factor that's often a problem are medications. Obtain a careful history, looking for temporal associations between changes in medical condition or medication and the emergence of the problem behaviors. And remember that psychosis in Alzheimer's is different. The delusions tend to be simple, a direct outgrowth of the memory loss. Someone stole my purse, because they don't remember that they actually have a memory problem and misplaced it. You've been a very attentive audience. I appreciate being here this morning. Thank you very much.
Okay, we have time for a few questions from the audience, and we just ask that you go to one of the people holding the mic so this way everyone can hear you. So while we're waiting for someone, I'll ask the first question. What's a physician? Oh, okay. Where? We have one back here? Okay.
Who's first?
Over here, you.
Me? Okay, thank you. My name's Helene. I'm a geriatric care manager, and often the difficulty that I see or I have is convincing or working with the physician. And how do you ask the question as a non-physician, Doctor, can you look at your prescriptions? Do you just have any suggestions?
I do, and I will be the first to admit, shock of all shocks, some of us physicians are a little egotistical, right? Unfortunately. But what I would say as a first step, do this. Say you went to the 20th anniversary UC Irvine ADRC conference, and you heard this guy from San Diego talk, and he was all about this issue with could medicines be a problem? Do you think it could?
Over here.
Is there any connection? Is there any connection? Here I am.
Right here.
Oh, sorry, okay.
Is there any connection between dyslexia and dementia, frontal lobe?
Oh, well, I'm going to defer that question. To my knowledge, I'm not aware of a connection, but I'm not an expert on that point.
Okay, Dan, we have one back here. Standing up.
Yes, go ahead, please.
Hi, my name is Donna Pick. In the last two cases that you talked about, I heard calcium deficiencies. Is that correct or not?
Not quite. It wasn't a calcium deficiency as much as it was an abnormality in calcium metabolism due to an oversecretion of the hormone, parathyroid hormone. Now, calcium deficiencies can pop up in the context of Alzheimer's and other dementias, but that wasn't this particular patient's issue.
Well, are you noticing that what you were talking about with the calcium and the parathyroid, that often is an issue?
I think it's important that we consider metabolic problems like deficiencies in calcium when we assess these people, and that's why our usual approach includes a battery of labs that would reveal if there was a calcium issue.
Thank you.